Hi, it's Jenny B, NSWOC. So today we're finally going to move on to the M in time, which stands for moisture balance. So moisture balance is actually one of the keys to wound healing, because if we don't have the moisture controlled, we're never actually going to get full granulation tissue up and epithelialization across and get that wound closed. So the key to moisture balance is that we want to keep a wound base or the wound bed not too wet, not too dry, just right, like the inside of your eye. So how do we achieve that? Well, we do with dressings. So again, I've talked a lot about some of the primary dressings, but then it comes into, okay, what are we going to use on top of those? So there's multiple choices, and I think this is sometimes where some of the confusing part comes in, because sometimes we're just changing dressings based on what was on it before, versus sometimes really looking at the wound bed, looking at the old dressing, seeing the amount of exudate that was on it, and then selecting a dressing that would be more appropriate to try to leave the wound longer depending on the amounts of drainage, or to try to reduce the amount of times that we are changing it. The thermal regulation of a wound comes with some of these fancier dressings that we do have. Way back in the day, we used to use a lot of gauze, a lot of wet to dry, where we would put wet gauze into a wound and then we would rip it out. One, it's non-selective dressing to bride or wound debridement, where it would take out a lot of the good tissue as well as the bad. And we also know that gauze penetrates through bacteria can penetrate through 60 layers of gauze, which is stack is about like this high. So again, gauze isn't a great secondary dressing, although you still will see it used. So what we do have nowadays is a lot of other dressings that actually pull or wick moisture out in a way so that it also traps it inside the dressing, so that it's not sitting on the patient's skin and causing any moisture associated skin damage. So again, it's looking at the different types and how much is actually coming out of that wound, so we can also try to reduce the amount of dressing changes we're doing, as well as ensure that the moisture balance is there and it's correct. So again, I'm going to start with some of the more common things that we see out there. Now, when I'm looking at moisture balance in any dressings, I'm really categorizing them between which dressings add moisture, which dressings maintain moisture, and which dressings remove moisture. So again, a lot of these are actually ones that are going to maintain or remove moisture. We're going to talk about those today. So I'll start with the lighter versions, or the ones that actually maintain. So I have done some videos on the clear acrylics, which again are something that does provide some moisture balance, great for skin tears, whatnot. They are out there, they are available, they are slightly absorbent, but they will maintain moisture. They won't maintain an environment that has a lot of exudate, or if there's an edematous limb and there's a lot of fluid coming out because of the edema. So we do have to kind of use your discretion as when we're going to use this. Again, they can stay on for several weeks, so it's something that you want very minimal exudate coming out of. Two things that I will note with moisture balance, that if you are noticing an increase in exudate, the main reasons are because of either infection or untreated edema. That edema can be on any limb. It's just something that's happening, and so now that it has an exit site, that you actually end up with increased fluid onto the dressings and leaky legs and whatnot. So again, these types of dressings that we're maintaining, they're not really appropriate for those type, unless again it's minimally exudating. So Telfa is a great product. We've had it around for many, many years. It's really just a small cotton pad, but it has a non-adherent on it. So it's kind of shiny, kind of glossy. It doesn't matter which side that you put down. But this is, again, for something that's minimally draining, or that we just want to cover because we're protecting it. Perhaps it's a new incision that we want to just cover, so that, while it seals in that 48 to 72 hours, that there's just something protecting it. Or if we're protecting an incision line that's maybe a couple weeks old, but because it's on an area where might rub on your pants or somewhere else, sometimes that's a really great option, just to have a layer of something in between. So Telfa, again, also for anything you're trying to dry out, or that's already somewhat dry and you're just maintaining, you can use it instead of having to use a bigger, bulkier dressing, unless of course there's a lot of leakage. So Telfa definitely has multiple uses. You can cut it. It doesn't harm it to cut and paste. Also, you're often going to need some secondary tape. So there's lots of composites that come that way already, but if you don't have it, if you only have Telfa and say a roll of tape, you can make just about anything out of it. But the other composites, there's lots that come that way already. This is this one that's basically a Telfa and tape, and so we call it a composite. So it's just a combination of the two dressings. Really nice when you're in acute care. Don't tend to have them a lot when you're out in the community. But again, just so that you're aware, you can just make it with the Telfa and tape. There are other types of composites. Again, a composite is basically just a Telfa or a piece of a non-adherent and then some type of tape around it. Usually it's either a film, which like these, so these are again just film and a Telfa pad in between, and they're just nice because they're peel and stick. That's why everyone likes them. So again, you can make that with Telfa if you have that, or if you have film, you can use that. So it's something that's minimally draining that you just want to cover or protect. So when we move on up the spectrum of, you know, amounts of moisture, so something minimally, we're going to probably stick to composites or Telfa. Something that's a little more moderately draining, that's when we get into foams. Now, foams have been around for several years. There's many different types. The key to a foam is that it is a moderately draining wound, something that, you know, we've likely treated the primary cause already, and that we're, you know, really just trying to help maintain. And the goal of foams is actually going to be changing them twice a week. So if you're changing them more frequently, it might not actually be the right dressing. Foams are actually quite expensive. So I don't have the 4x4. Oh, I do. In my pickle trunk, I always have this stuff. The small 4x4s themselves retail for about $10. So again, people want to get stuff, I'll tell them, go on Amazon. These are actually quite expensive. So as a nurse, if we're putting, you know, we might not be paying that for it, but you know, it's an expensive dressing to be putting on a wound, especially if you're changing it on a daily basis. Yes, sometimes we need to use it because of the silicone or the tack, which I'll talk a little bit more about. But again, it's not something that if you are, then we might want to look at some of the composites, the Telfas, something else that we could be using if we're having to change it on a daily basis. So again, just be aware of the actual cost of those, because again, it can be quite exuberant for a daily dressing change. Now, foams, again, I actually carry two main ones here. One is one with a film border. So this is, the nice part about this is it's a non-adherent foam. So on the opposite side, there's no sticky, there's no tack on it. So it doesn't stick to the patient's skin or the peri wound. Where the silicone dressings, these actually do have tack on both sides. So even on the actual foam piece itself, this is actually quite tacky. So when you're putting that right on top of a wound, and if you don't have a primary dressing, sometimes it actually can adhere too much and can be painful, or, you know, sometimes that's what you want. You want to be able to sit on quite well. So again, just to be aware that, you know, there is non-adherent foams and then adherent foams. And again, we also have to be aware if the patient is having any allergies. So the silicone, for the most parts, we are to be using when a patient does have some tape allergies. But for the most part, I try to stick to a film. The nice part about film is I can also use a skin barrier underneath it. There's lots of no stings. There's Cavalon, even most of the ostomy companies also carry them as well, that you can use underneath here. There's no sting skin prep, I believe, like those types of things underneath. So that can actually help. The reason we want to use skin preps under these is because it will actually also prevent any device related tears. So it will help the skin you know, a lot of people are like, oh, we use the skin barrier so that it sticks better. Well, yes, it's one of the lovely things that we have found that it does, but it's also to put a barrier there so that when you remove it, you're not tearing any of the skin. Because tapes have a tendency to do that. The other bad thing sometimes we do with tape is that we end up stretching the dressing, and that stretch actually causes tape injuries. So we want to be aware of that. So with the foams, for the most part, we want to, again, be choosing these when it's a moderately draining wound, and that we're going to be changing the foam no more than twice a week. Again, 3 times sometimes, especially if you have to go to a silicone because they have allergies. That's the primary reason we're really supposed to be sticking to some of the silicones. And again, so for something moderate. The one last little fancy product I do want to talk about is Biotin IBU. So it is a non-adherent foam as well. That the goal of this stuff is that it actually has ibuprofen impregnated into the foam itself. So it can help, it can be really, really effective for pain. So this is something that, again, for the most part, they only allow the NSWACs to order, or that someone with a specialty will do that. But one of the main reasons we're using it is because, again, it is a non-adherent, but B, that there's 0.5 milligrams of ibuprofen per centimeter square of this dressing. And that can actually do two things. One, it can actually help with inflammation. The other, it can actually, again, be very effective on something that's quite painful. Again, though, also only for a moderately draining wound. The other benefits to foams is that they actually allow for fluid to evaporate out the back. So if we cover over this foam with a bunch of tape, you're not actually allowing the dressing to do what the dressing is supposed to. You can, however, use one layer of film. So as you see with these dressings, there is one layer of film around it. You can use one layer of film with the biotin IBU because it is semi-permeable and it will still allow for fluid to evaporate out. So that's kind of the keys with foams and when we're going to use them. Now I'm going to switch over now to kind of our super absorbent. So the Pampers of wound care. Well, they aren't all, but again, kind of put them in a category as to which one we're going to use first. So if you have leaky legs, everyone's probably seen these before, where there's just fluid upon fluid coming out because they have CHF or they have lymphedema or edema that's not been controlled to start, and you are changing these twice a day because they're just soaked. Well, for the most part, a lot of us still will use abdominal pads. The reason is because they're super cheap. You can use tons of them, and again, because of the size, they cover a large area. Now, abdominal pads have a little bit of fluff in them. They are somewhat absorbent, that they, will handle a fair amount of fluid when that's what your goal is to absorb it. Now, I actually use these a lot to irrigate. When I'm irrigating out a wound, I actually will put this underneath so I catch it and I don't get myself soaking wet. But again, the abdominal pads, so number one, blue line always goes upward so that that's what's going to be on top of the body. B, you can cut through this so that multiple layers can be placed and it will actually go through. But again, we're choosing usually abdominal pads when you have something large. So when you have something smaller, when you have a diabetic foot ulcer, you have something, just a little toe that you want to put a little square on, we can use Mesorb. So Mesorb, again, it's a little more absorbency than the abdominal pad, but it's a little softer, this fluff that's in here, so it'll actually help to pull and wick some of the moisture out and away from the wound itself. The Mesorb itself you can cut. When you do cut it, it actually seals. There's a small little line that you'll see right across there that when you do cut it, it will seal some of the foam so it doesn't actually leak out. Again, when you have this wide open, as long as you do have this taped onto the patient, it will actually provide a lot of absorbency. This is actually my preference always on a foot. The reason why is foam, again, when you put it in a shoe, yes, the moisture is trapped, but as I was talking about how some of that fluid is to evaporate outside of the foam, when it's in a shoe, it can't do that. So then you end up with wounds that are quite wet and macerated, and when there's that maceration, foam is not the right dressing for it. So you'll see me ordering the Mesorb for that, especially when their foot is in a shoe. Now, Mesorb again comes in multiple sizes. I love this one because it's a nice incisional dressing. So if you do have something leaking out of an incision, you can put these right across, and it's a little more absorbent than, say, a composite, which is what we use in surgical care quite often. Now, again, the Mesorb has to be taped on, so you do need something secondary. But again, when you have something draining a moderate amount, definitely it's a great choice. Now, the Pampers of wound care is actually Mextra. Mextra is actually a very thin dressing. It's almost twice as absorbent as Mesorb, and it will actually puff up quite a bit. So this is for something that there's large amounts of drainage that you need to control, and it does come in multiple sizes as well. And again, it's the exact same thing as diaper technology, where you put a baby to bed and then they pee and pee and pee overnight, and then the diaper gets bigger and more swollen. Well, it's actually the same type of technology. So that is another option that we do have in wound care, especially when it's something highly exudating. So again, I hope this is helpful to help explain some of the differences between the dressings that we use when we are trying to maintain moisture balance. And again, don't forget, the best type of wound is a closed one.